Bismillahirrahmanirrahim. Today we have talked about covering of the brain and spinal cord called meninges. We discussed about three layers: dura mater, pia mater, and arachnoid mater. Then we talked about dural venous sinuses. Then we discussed about five types of hemorrhages and headaches associated with meninges. Starting from the very beginning, this diagram, starting from the skin, you can say scalp, skin, connective tissue, and then aponeurosis, loose connective tissue, and pericranium. First of all is skin, then we have another layer which is having, you can see these are the superficial fascia, and between the superficial fascia we have superficial veins of scalp, then we have superficial nerves of scalp, then below that we have a subcutaneous, this layer, we can say in this layer, this is called you can say epicranial aponeurosis, and this is what pericranium or periosteum, and this is connective tissue layer. And this connective tissue layer we have a vein called emissary veins. It is a valveless vein which connects superficial vein of scalp and diploic veins. And this is the, you can say periosteum, sorry, parietal bone, and central part is called diploid. What is diploid? It is a spongy cancellous bones which separates the outer and inner tablet of the cortical bones of the skull. You can see over here, this is the diploids, and this is the outer, and this one is the inner cortical part of the parietal bone. You can see over here, you can see simply, this is the outer and inner table of the parietal bone, and in between this bone we have a cancellous spongy bone called diploid. In this diploid we have diploic veins which are draining into the superior sagittal sinus, and in below this periosteum, or you can say bone, parietal bone, we have a dura mater layer, and there are two layers of dura mater, endosteal layer and meningeal layer. These two layers are with close proximity with each other. They are together, except two places they are separate from each other. One is the dural venous sinuses and another is foramen magnum. And then you can see over here, this is the endosteal layer, if you can zoom it, endosteal layer, and this one is meningeal layer of the dura mater, and it goes downward, and it makes a falx cerebri and makes an inferior sagittal sinus. And this falx cerebri, the sinus present superior to the falx cerebri is called superior sagittal sinus, and this sinus present inferior to the falx cerebri is called inferior sagittal sinus. And then we have, after the dura mater, we have arachnoid mater. This is the arachnoid mater layer, and this space is called subarachnoid space, having cerebrospinal fluid and cerebral arteries and veins. And moreover, these arachnoid layer at this part makes arachnoid villi, and the combination or a collection of these villi or arachnoid villi will collectively called as arachnoid granulations, which are very helpful in the drainage of the CSF into the dural venous sinus, especially the superior sagittal sinus. Then we have pia mater, the most you can say close proximity with the cerebral cortex. Pia mean loving, mater mean mother, most loving mother. Every time associated with the cerebral cortex, and it also covers the cerebral arteries. We discussed about cerebrospinal fluid, then we discussed that pia mater with choroidal arteries are called telachoroidi. When associated with the ependymal cells, it is called choroid plexus. Okay, now we will talk about from the dura mater, because this is the you must understand this diagram. Then we will go to the first layer of the meninges called dura mater. Dura mean hard, and mater mean mother. It is a hard mother. It is most thickest and toughest layer as compared to arachnoid matter and pia mater. And if we talk about its layers, its sensory having sensations or association with the trigeminal nerve, vagus nerve, C1 to C3, and sympathetic trunk. If we talk about, there are two layers of dura mater, endosteal layer and meningeal layer. The endosteal layer is kind of periosteal covering, having connection with the sutural ligaments. It connects with the brain, and there are separation of endosteal and meningeal layer at two places. One is foramen magnum and another is dural venous sinuses. You can see over here, sutural sinuses separated, dural venous at the dural venous sinuses and the foramen magnum. And then blood vessels, blood supply of the dura mater is internal carotid artery, ascending pharyngeal artery, maxillary artery, occipital artery, vertebral artery. Most importantly, branch of maxillary artery at the level of infratemporal fossa passing through the foramen spinosum called middle meningeal artery, and the most commonly ruptured artery in the head trauma, head damage. Especially the level at the posterior. What is posterior? It is a junction of frontal bone, parietal bone, temporal bone and sphenoidal bone called posterior. You can see anterior and inferior to the parietal bone, and the opposite part of the posterior we have asterior, junction between the occipital bone, parietal bone and temporal bone called asterior. But because this posterior is the most weakest part of the skull, if someone is having blow at this part, then mostly chances are the rupturing of the middle meningeal artery. That will cause a pressure over the, you can say, due to that clot, due to hemorrhage, pressure of the precentral gyrus and intracranial pressure will be the clinical features. Okay. Head injury most commonly rupture middle meningeal artery over the infratemporal fossa maxillary artery becomes middle meningeal artery passing through the foramen spinosum, and posterior present anterior and inferior to the parietal bone, and posterior present between frontal bone, parietal bone, temporal bone and sphenoidal bone, and opposite to the posterior we have asterior. Okay. Okay, then we will discuss about Falx cerebri. What is Falx cerebri? You can see over here. This is the crescent-shaped fold of dura mater, this Falx cerebri, which separate two cerebral hemispheres. And posterior part of the cerebral Falx cerebri is Tentorium cerebelli, which is also a crescent-shaped fold of dura mater, which separates cerebrum to the cerebellum, which loads the occipital lobe. And you can see our Falx cerebri is a sickle-shaped fold of dura mater present between the two cerebral hemispheres. And superior to this Falx cerebri we have a superior sagittal sinus, and inferior to this Falx cerebri we have a inferior sagittal sinus. Okay. Then okay, you can see over here. Inferior to the inferior sagittal sinus, and posterior to this we have Tentorium cerebelli, which makes the roof over the posterior cranial fossa. It is a fold of dura mater called crescent-shaped fold of dura mater called Tentorium cerebelli, which separates cerebrum to the cerebellum and which holds the occipital lobe. And anterior to the Tentorium cerebelli we have tentorial notch, which gives passage to the midbrain or mesencephalon. And inferior to this Tentorium cerebelli we have Falx cerebelli. You can say sickle-shaped again. Sickle-shaped fold of dura mater, which separates the two cerebellar hemispheres, and you can see over here. And we have another structure called diaphragm sella. It is also a fold of dura mater called circular fold of dura mater, which covers the sella turcica with a central hole for the stalk of pituitary gland, for the stalk of hypophysis cerebri. You can see over here, if I make it a little diagram for you. Suppose this is a sella turcica, and here we have a diaphragm sella, as you can say circular fold of the dura mater having central hole for the stalk of the pituitary gland or hypophysis cerebri. You can see over here. This is sella turcica. Here we have cavernous sinuses. We will discuss here. This is sella turcica. This is diaphragmatic sella folding of the circular folding of the dura mater with a central hole for the stalk of the hypophysis cerebri. And then okay, you can see over here with a hole for the stalk of the hypophysis cerebri. Then we will talk about, yes, dural venous sinuses. If we talk about the dural venous sinuses, these are the thin-walled valveless structures. Imaginary vein, it is also a valveless structure which connects the diploic veins and the superficial veins of skull. And most importantly, first of all, is superior sagittal sinus present superior to the Falx cerebri. And lateral to the superior sagittal sinus we have venous lacuna, which drains the diploic veins and meningeal veins. And interior to the superior sagittal sinus we have foramen cecum, which drains blood from the nasal cavity. And then okay, we have talked about this. Suppose this is the you can say endosteal layer. It covers the whole the brain, called of periosteum covering with a sutural ligament till the foramen magnum. And after the foramen magnum, only the meningeal layer covers the spinal cord. This meningeal layer that covering the spinal cord, it covers the spinal cord till the end of filum terminalis at the lower border of the second sacral vertebra, at the lower border of S2. And if we talk about the epidural space, suppose a meningeal layer of the dura mater which are covering the spinal cord, passing through the central canal, the epidural space which will be made up of areolar connective tissue. You can see over here loose areolar connective tissue plus internal vertebral venous plexus. Okay, then we will talk about exact diagram of the dural venous sinuses. You can see over here, this is superior sagittal sinus present above the falx cerebri. It is a you can say fixed part, but inferior sagittal sinus is a free end. And superior sagittal sinus will drain into the confluence of sinus. Then inferior sagittal sinus below the falx cerebri joins with the great veins of cerebellum. Great veins of Galen, great cerebral veins of Galen, like deep veins of cerebrum. They join together at the level or the junction of the falx cerebri and tentorium cerebelli. And after the joining of great veins of Galen plus inferior sagittal sinus, it becomes straight sinus. Then straight sinus also drain into confluence of sinus. Then we have occipital sinus, which drains the blood from the falx cerebelli. It also drain into confluence of sinus, and this confluence of sinus will drain into transverse sinus. Transverse sinus also get blood from the diploic veins, from the inferior cerebral veins and cerebellar veins. Inferior cerebral vein drain into transverse sinus and superior cerebral vein drain into superior sagittal sinus. This transverse sinus go along with the tentorium cerebelli, and when it go down from the level of tentorium cerebelli, it becomes sigmoid sinus, and sigmoid sinus is present at the mastoid antrum, mastoid part of the temporal bone. And if there is any kind of otitis media, middle ear infection, you can say otitis media or mastoiditis. Okay, if there is a problem over here, then sigmoid sinus will be infected, then transverse sinus and superior sagittal, whole sinus system will be infected, and the CSF absorption will be affected. And due to this otitis media or mastoiditis, there is a pathology called otitis hydrocephalous can happen because sigmoid sinus proximity with the mastoid antrum. Then when this sigmoid sinus crosses the jugular foramen, it becomes internal jugular vein, and there is no fun in telling. Internal jugular vein combined with subclavian vein, combined with external jugular vein, vertebral vein becomes brachiocephalic vein, right brachiocephalic vein joined together with the left brachiocephalic vein and becomes superior vena cava, and superior vena cava also get blood from the azygous vein at the level of T4. So now we will talk about this cavernous sinus. See, at the lateral side of this sella turcica we have two cavernous sinuses. You can see over here right and left. Cavernous sinus have a connection with each other anterior and posterior by anterior and posterior intercavernous sinuses, and they get blood from superior ophthalmic vein, inferior ophthalmic vein, inferior cerebral veins, sphenoparietal sinus and central lateral vein. The blood from these veins will go into cavernous sinus, and from the cavernous sinus via superior petrosal sinus blood go to the transverse sinus, and via inferior petrosal sinus blood will go to the internal jugular veins. And one thing more clinically, these anterior and posterior intercavernous sinuses have association with the facial vein, especially the superior ophthalmic vein. It is a source of infection. If someone is having infection from the superior ophthalmic vein, then through the superior ophthalmic vein, this anterior and posterior intercavernous sinus will get infected, and it will infect the cavernous sinus. The inflammation of the cavernous sinus is called cavernous sinus thrombosis. And if someone is asking if cavernous sinus becomes infected, what will be the consequences? You must know these things. This mnemonic called O-Tomcat. If you know the content present in the cavernous sinus, then you can answer. If there is a problem at the center of the cavernous sinus, then abducens nerve and internal carotid artery clinical feature will be shown by these. Then if there is a lateral part of the cavernous sinus being damaged by trauma, tumor, infection, then these features will be disturbed. A mnemonic called O-Tomcat. O for oculomotor nerve, third cranial nerve. T for trochlear nerve, fourth cranial nerve. O for ophthalmic division of trigeminal nerve, 5A. M for maxillary division of trigeminal nerve, 5B. These four structure crosses at the lateral wall of the cavernous sinus. If there is any trauma or tumor infection damages the lateral wall of the cavernous sinus, then clinical feature will be related to these four structures. If there is trauma tumor, any kind of infection to the central cavity of the cavernous sinus, then maybe internal cavity artery and abducens nerve will show damage. And we talk about LR4SO6 for the extraocular muscle, means lateral rectus will get innervation by 6th cranial nerve, abducens nerve, and superior oblique muscle get innervation by 4th cranial nerve, that is trochlear nerve. So if someone is saying that someone is having increased intracranial pressure, infection to the cavernous sinus or cavernous sinus thrombosis happened, and person can't see right with his right eye. If see I'm looking at the right side, the right eye showing the lateral rectus and left eye which muscle is working, medial rectus. If someone is saying a person can't see right with his right eye, it means lateral rectus is damaged. It means the center of the cavernous sinus is damaged, because abducens nerve is present at the center of the cavernous sinus. That's why you must understand and learn by heart these mnemonic with these lateral walls and central cavity of the cavernous sinus. And then, okay, we will talk about now, after this discussion, we will talk about, yes, again, dural venous sinus. This is the superior sagittal sinus, inferior sagittal sinus, straight sinus, left and right transverse sinus. Then we have, okay, this is what endosteal layer of the dura mater. This is what the meningeal layer of the dura mater. Then we have over here tentorial notch. This is the Falx cerebri. This is the tentorium cerebelli. This is the tentorium notch having passage to the midbrain. And then we have discussed that from the transverse sinus, brain will be go to the sigmoid sinus as it leaves the tentorium cerebelli. From the sigmoid sinus, when it crosses the jugular foramen, it becomes internal jugular vein. Internal jugular veins, you can say, will drain into subclavian veins. And this meningeal layer of the dura mater will cover the spinal cord and till the lower border of the second sacral vertebra. Okay, then we will talk about first of all dura mater, now arachnoid matter. Arachnoid mean spider web or cobweb web structure, and it fuses with the sclera. You can see over here. So this is the sclera. This is sclera. This is the eyeball. This is lens, iris, ciliaris muscle, cornea. No need. This is the optic nerve. This one is optic nerve, covered by pia mater. Then pia mater having covered of arachnoid matter. And then we have dura mater covering. And arachnoid is in subarachnoid space. We have a flow of cerebrospinal fluid. So that is why optic nerve is called not a true cranial nerve. Why? Because optic nerve is an extension of the brain, and due to this extension of the brain, the arachnoid matter fuses with the sclera of the eyeball. Okay, that's why if someone is having intracranial pressure, increased intracranial pressure will lead to the pupillar edema. Okay, come back. Arachnoid matter, it is an impermeable, transparent and delicate membrane. It is having, in subarachnoid space we have cerebral artery and cerebral veins, and arachnoid villi, they join together to make arachnoid granulations for the CSF drainage into the dural venous sinuses. Then subarachnoid space, yes, CSF flowing. Then there are few systems now. Pia mater and arachnoid matter, they are very close to each other. You can say go together, but there are few separations of these arachnoid and pia mater. This is called cisterna. Cisterna pontis, cisterna medullaris, cisterna interpedicularis. You can see over here there is a separation of the cisterna magnus mean from the cerebellum and medulla oblongata, cerebellum and pons, and interpeduncular means between the cerebral peduncles. There these three places, and have more places also in which arachnoid matter and pia matter separates from each other. Then arachnoid matter plus pia matter is called leptomeninges. If there is infection to the meninges, called meningitis. If there is infection to the cerebral cortex or cerebral tissue, is called encephalitis. If there is infection, inflammation of the spinal cord, called myelitis, and inflammation, infection of the spinal cord plus brain tissue is called encephalomyelitis. These are a few terminology we have discussed. Then pia matter, pia mean loving, matter mean mother is a loving matter. Always stay with their kids, always stay with the cerebral tissues. Even it also covers the cerebral cord, cerebral arteries. It is a vascular layer. It covers the cerebral arteries at the third, fourth, and lateral ventricle. And due to the covering of the cerebral arteries, becomes tela choroidi, and tela choroidi plus ependymal cells called choroid plexus, and and as pia mater covers the spinal cord, at the lateral side of spinal cord become thickened between the nerve root that makes up due to the thickening of the pia mater to the lateral side between the nerve root is made ligamentum tentaculum, and pia mater also covers the gyri and descend to the deep sulci. But the arachnoid matter don't have such characteristics, don't go deep to the deep sulci. And then we have pia mater, is covering of mesothelium. Then we will talk about 5 types of hemorrhages and 5 types of headaches. First of all, epidural hemorrhage due to the damage to the middle meningeal artery, especially the anterior branch. First of all, the paralysis of the face will happen. Then in epidural hematoma we have a lens-shaped hyperdense collection of blood. You can see over here. Epidural anterior branch of the middle meningeal artery will be damaged. Then paralysis starts from the face. No blood in the CSF in epidural hematoma, epidural hemorrhage, and lens-shaped hyperdense blood collection. Then we have subdural hematoma. This happened due to this, especially the superior cerebral vein. In epidural we have middle meningeal artery, but in subdural we have veins. Most importantly, superior cerebral vein, and there is a crescent-shaped hyperdense blood circulation, and there is haphazard paralysis because like unorganized, because without any plan and organization, haphazardly paralysis will happen. In subdural hematoma, you can see over haphazard paralysis. The superior cerebral vein will be mostly involved, and superior cerebral vein at the entrance of the superior sagittal sinus. Then crescent-shaped hyperdense blood circulation. Then we have subarachnoid hemorrhage due to the aneurysm. We have talked what is aneurysm, abnormal dilatation of the arterial valve. Then aneurysm is most commonly present in the circle of Willis. Most common artery is anterior communicating artery. Second most is posterior communicating artery. If the aneurysm, the abnormal dilatation of the anterior communicating artery ruptures, then there is a hemorrhage in the subarachnoid hemorrhage, or maybe due to the angioma, or maybe due to any contusion like brain tissue damage with the blood vessel rupture, and maybe angioma, maybe overgrowth of the capillary network, or maybe due to the laceration in the brain tissue and the meninges. Subarachnoid, and the neck will be stiffened, neck stiffness, headache, progressive, continuous. Treatment is ligature of the arteries. Okay, you can see aneurysm. Then we have angioma, contusion, laceration of the brain and meninges. And for diagnosis, CT scan is the best, and lumbar puncture can also be done to diagnose the pathology. Then we have intracerebral hemorrhage due to molding. And what is molding? It is a process in which the fetal circumference of the fetus becomes narrow or decreased. Due to this, suppose this is the parietal bone and the pelvic outlet is very narrow of the mother, then these parietal bones, due to membranous ossification, has a capability to interdigitate or overlap with each other to decrease the diameter of the fetal head and to help in easy delivery, and after the delivery they again come back to their normal places. So due to this molding process, cerebral tissues can be damaged, cause intracerebral hemorrhage. And there's no fun in telling membrane ossification is very having a still due to this membrane ossification having a process called molding, plus some places like between the frontal lobe and parietal lobe we have a fontanelle called anterior fontanelle. Then we have posterior fontanelle because they ossify. Suppose the posterior fontanelle ossify at the age of 1.5 years and anterior fontanelle ossify at the age of 2 years. Then we have sphenoidal and occipital or temporalis fontanelle also present. Okay, then come back over here in the intracerebral hemorrhage molding. Then we have lenticulostriatal hemorrhage. What is lenticulostriatal artery? It is a branch of middle cerebral artery. We have discussed when we discussed about the blood supply to the head and neck. Middle cerebral artery gives a branch to lenticulostriatal artery. And due to the rupture of the lenticulostriatal artery, damage to the internal capsule, and due to damage of the internal capsule, there is a damage to the corticobulbar and corticospinal tracts or fibers. And due to these lesion at the corticospinal corticobulbar tract, there is contralateral hemiplegia. Clinical feature will be seen in the patient. So lenticulostriatal artery rupture may lead to the intracerebral hemorrhage. Then we have due to internal capsule, corticobulbar and corticospinal tract will be damaged. Then it will lead to the contralateral hemiplegia. Then lateral ventricle damage, or pons damage, or cerebellar damage may lead to the intracerebral hemorrhage. Then we have intracranial hemorrhage due to the some veins and some sinuses rupture. Which vein? Great cerebral veins. Which sinuses? Inferior sagittal sinus and straight sinus lead to the intracranial hemorrhage. Then we have headaches. First of all is meningeal headache. If the, keep in mind one thing, that above the tentorium association with the trigeminal nerve, and below the tentorium cerebelli association with the cervical nerves, great auricular nerve most probably. If there is a pain or you can say irritation with the trigeminal nerve, or you can say above the tentorium cerebelli, trigeminal nerve is involved and face headache at the face and the forehead. Below the tentorium, due to cervical nerves involvement, headache at the back of the neck and head. Then we have, after this meningeal artery, okay, for above the tentorium cerebelli, fifth cranial nerve, and below the tentorium cerebelli, C1 to C3, back of the neck and head. Then we have migraine headache. It may be unilateral or, unilateral or bilateral, due to vasoconstriction of the veins coming from the visual cortex or vasodilation of the cerebral arteries, because visual disturbance is the key feature in the migraine headache. So that's why we give beta blockers, which reduces the vasodilation. So what happens in the migraine? Unilateral bilateral hemorrhage, unilateral or bilateral headache with the vasoconstriction of the veins coming from the visual cortex, because visual disturbance is main feature, and vasodilation of the great cerebral arteries, other cerebral arteries. So due to this feature, we give beta blocker to reduce the vasodilation, to do the vasoconstriction, to help in migraine. Other drugs are somatriptan will be given in the migraine. Then we have headache due to cerebral trauma. Again, if there is trauma above the tentorium cerebelli, then due to the trigeminal nerve involvement, the headache will be at the face and the forehead. If the cerebral trauma below the tentorium cerebelli, then cervical nerves are involved and headache will be at the back of the neck and head. Then we have headache due to teeth, paranasal sinus. Paranasal sinus is an eye, and there is no fun in telling. Teeth and paranasal sinuses headache will be at the face and forehead, and in eyes, due to the spasm of the ciliaris muscle called cycloplegia, there will be orbital hemorrhage, and it can also happen in the patients who are trying to use the lenses for the presbyopia. We know at the age from the 45 to 60 years old, 60 years, normal tendency, it is called senile presbyopia, you can say, due to with the age from 45 to 60 years of age, the near vision becomes disturbed, and if someone is not using lenses for that, it may have orbital headache. Then last but not the least, we have alcohol headache, because alcohol have a toxic effect on the meninges. So these 5 types of headache you must not forget. 5 types of hemorrhage with these clinical features you must not forget. Then arachnoid matter characteristics features, and this one as extension of the, we know the retina. Retina is the extension of the diencephalon, and olfactory bulb is the extension of the telencephalon. Am I right? Am I right or not? You have to answer this in the comment box. Then we have cavernous sinus. We have discussed it is present lateral to the sella turcica. What is sella turcica? It is the base of the sphenoid bone, having a place for the home for the pituitary gland, hypophysis cerebri, and laterally to the sella turcica. Laterally we have cavernous sinuses, and cavernous sinuses having drainage to the transverse sinus through superior petrosal sinus and to the internal jugular vein by inferior petrosal sinus, and have a connection with each other with anterior and posterior intercavernous sinus. It is also a source of infection due to the facial vein and especially superior ophthalmic vein. And sigmoid sinus also have a source of infection from the middle ear infection or the mastoiditis lead to the otitis hydrocephalous. Because we know what are the sinuses are doing, dural venous sinus, they are draining the CSF, right? Normal in one day we have 500 ml secretion of the CSF, and one day 350 ml will have to be reabsorbed. And if there is a infection over here or obstruction over here, then what will happen? CSF absorption will be disturbed. It will increase the intracranial pressure, and it will have consequences like maybe pupil edema or maybe other features. You can see increase in, we have communicating hydrocephalous, non-communicating hydrocephalous. Okay, in the mnemonic you must not forget. Then this diagram is very important. Diploid veins are very important. Then the other features like Falx cerebri, Falx cerebelli, Tentorium cerebelli, then diaphragm sellae. So these are the structures you must not forget whenever you are preparing for the meninges. The covering of the brain and spinal cord.